I put my slides up. Can people see them? Yes?
Yes, we can see your slides.
Okay, good. Give me 1 second here. Okay. Okay. I have a big, there we go. So I'm going to talk about about 20 pregnancy-related abstracts from CROI. And I'm going to start by talking about SARS-CoV-2 COVID-19 pregnancy and pregnancy outcome. And the first study I'd like to talk about was reported by Jim Njaka. And he has 22 sites in 6 countries in Africa, as shown you on the map. And he looked at women of childbearing age admitted to the hospital and tested for SARS-CoV-2. And he evaluated the dual interaction of pregnancy on SARS-CoV-2 infection and SARS-CoV-2 infection on pregnancy outcomes. And this shows you the adjusted relative risk of outcomes in SARS-CoV-2 infected women by pregnancy status, with pregnant women being shown in red in the Kaplan-Meier curve and non-pregnant women with SARS-CoV-2 in green. And they looked at ICU admissions, oxygen therapy, mechanical ventilation, and mortality. And you can see both in the adjusted relative risk table, as well as the cumulative incidence for mortality, that in women with SARS-CoV-2 infection, there was an increased risk of ICU admission, oxygen therapy, and mortality in pregnant compared to non-pregnant SARS-CoV-2 infected women. And this is a very similar graph, but looking at pregnant women by SARS-CoV-2 status, with pregnant women who are infected shown in red, and pregnant women who are SARS-CoV-2 uninfected in green, and looking at the same outcomes. And you can see in pregnant women, there was an increased risk of ICU admission, oxygen therapy, and mortality in pregnant women with SARS-CoV-2 compared to pregnant women without SARS-CoV-2 infection. So these data are similar to that seen in the US, but finally getting some data from Africa. This study came from Botswana and looked at the impact of COVID-19 on adverse birth outcomes by HIV status. And they used the Tisambo birth surveillance infrastructure, where they began to do routine COVID-19 screening at delivery, and they evaluated singleton birth outcomes by HIV and COVID-19 status. And there were over 20,000 deliveries, 56% of them screened, with 539 or 4.7% being COVID positive. And you can see in the red box there that HIV positive women were more likely to be COVID positive than HIV negative women, 5.6 versus 4.3. Now this looks at adverse birth outcomes by COVID status. And you can see COVID positive, COVID negative, and you can see that there were high rates of serious adverse birth outcomes in women who were COVID positive. And in particular, I'll bring your attention to stillbirth, 5.6 versus 2.7%. They then looked at maternal mortality. And if you just look at the top row here, you can see that maternal mortality was significantly higher in COVID positive compared to COVID negative women. This was higher during the Delta stage, 2% pre-Delta, 5% post-Delta. But in the red box, you can see that maternal mortality did not differ by maternal HIV status. And then finally, they looked at adverse birth outcomes by COVID and HIV status. So the blue dots are HIV positive women who are COVID negative. The orange dots are HIV negative women who are COVID positive, and the yellow are HIV positive women who are COVID positive. And if you just look at the little dots, you can see that the highest rates of all of the adverse outcomes were in HIV positive women who had COVID compared to HIV negative women with COVID or HIV positive women without COVID. So HIV status appears to exacerbate the adverse birth outcomes. This looked at neutralizing antibody response in pregnancy and transplacental transfer. They enrolled 238 pregnant women with confirmed infection and evaluated antibody at enrollment, delivery, 6 months postpartum, and also infant blood at 24 hours and 6 months. So this looks at maternal antibody by disease severity, looking at IgG, IgM, and IgA, with asymptomatic women in gray, mildly symptomatic women in blue, and severe or critical COVID in red. And you can see that at delivery, there were significant differences in maternal IgG, IgM, and IgA antibody levels by maternal disease severity, with the lowest level in those that are gray, the asymptomatic, and the highest levels in women with severe disease in red. Now, this looks at maternal antibody at delivery and infant antibody at birth by maternal vaccination status, with unvaccinated women being shown in purple and vaccinated women or infants of women in blue. And you can see that delivery IgG levels were higher among vaccinated than unvaccinated women post-infection, and also in their infants born to vaccinated mothers compared to unvaccinated mothers. A transplacental IgG transfer correlated with increasing duration between diagnosis date and delivery. Infant IgG levels significantly decreased by 6 months postpartum, not surprising. And in a subset analysis, only 68% of unvaccinated mothers and 42% of infants of unvaccinated mothers had evidence of protective neutralizing activity at delivery. Vaccination could be good not just for the mother, but for the baby. This last study in the COVID section looks at Remdesivir PK and safety in pregnant and non-pregnant women from Impact 2032. This shows you, the little figure shows you Remdesivir pharmacology. Here's Remdesivir, the prodrug, and the different metabolites. And they looked at PK in 21 pregnant and 28 non-pregnant women with COVID-19. So this graph shows you the plasma concentration time curves for Remdesivir and each one of the metabolites, comparing pregnant women in blue to non-pregnant women in purple. And then in the right-hand side, you see a table with the intensive PK results. And you can see even just from the graphs that there were no significant differences in PK parameters between pregnant and non-pregnant women. This looks at adverse events through infusion and 4 weeks post-last infusion, again, by pregnancy status, pregnant women and non-pregnant women. And the first thing is that AEs were not uncommon at all in women with COVID-19. That's not surprising, but only 2 AEs were deemed related to Remdesivir, and both of those occurred in non-pregnant women. And pregnancy outcomes were similar to those reported in studies of hospitalized pregnant women with COVID-19, with elevated preterm delivery rate, 10% SGA, 1 intrauterine fetal demise. None of these were deemed Remdesivir related. So moving on to antiretroviral drugs in pregnancy. So this study looked at weight gain with raltegravir versus efavirenz during pregnancy, NICHD P1081. And this study compared raltegravir versus efavirenz-based treatment initiated at 20 to 31 weeks gestation. And the study evaluated gestational weight gain in 281 women who were on the study. So here we see in green efavirenz and in purple raltegravir. This shows you the rate of BMI change by treatment arm. And you can see that raltegravir compared to efavirenz was associated with higher antepartum weight gain and, as shown in the graph, higher BMI increase. So then they looked at the rate gain being low, normal, or high, as shown in the graph here. Again, efavirenz in green, raltegravir in purple. And women on raltegravir ART were compared to efavirenz were less likely to have low weight gain and more likely to have normal or high weight gain compared to those on efavirenz. And then they looked at, compared to normal weight gain, they looked at adverse pregnancy outcomes. And in the red box, I highlight the important ones. And compared to normal weight gain, women who had low rate weight gain had significantly more SGA infants or composite adverse pregnancy outcomes. However, if you compared high versus normal weight gain, there was no difference in adverse outcomes. So having a low weight gain was associated with adverse pregnancy outcome, and low weight gain was more common with efavirenz. This study comes from a vested study that compared dolutegravir TAF, dolutegravir TDF, and efavirenz in pregnancy. And there was more gestational weight gain observed with the dolutegravir arms than with the efavirenz arm in the trial. And they looked at metabolic consequences by evaluating hemoglobin A1C and random glucose at entry, 12 weeks, and at delivery, and neonatal glucose in a subset enrolled in the trial. So here we see a graph of hemoglobin A1C by study arm, and here we see high pre-diabetic hemoglobin A1C at week 12 in delivery by study arm, with the light blue showing you dolutegravir TAF, the orange is dolutegravir TDF, and the dark blue is efavirenz TDF. And so while there was a trend towards higher hemoglobin A1C with dolutegravir TAF, if you look, there was no significant differences overall or in pre-diabetic levels. And the bottom table shows you maternal and infant glucose by study arm. And you can see from these p-values that there was no difference between dolutegravir versus efavirenz or TAF versus TDF, despite the fact that there was difference in gestational weight gain between the regimens. So metabolic consequences were not seen. This is also from the vested trial looking at HIV drug resistance. So in the vested trial, dolutegravir had significantly lower rates of viral failure compared to efavirenz. So they looked at people who had viral failure defined as RNA greater than 200 on 2 consecutive tests after greater than 6 months of treatment, and did genotyping on confirmed failure in entry specimens. So this shows you the proportion of women with virologic failure on the top and the proportion of women with drug resistance at virologic failure on the bottom. And what you can note on the top in the orange box is that there was more viral failure with efavirenz than with the dolutegravir arms in the green. Most of the viral failure specimens were able to be genotyped, and HIV drug resistance was present in 83% of those who had viral failure. And you can see in the orange box that drug resistance at viral failure was more common with efavirenz than dolutegravir, but did not differ in the green box between dolutegravir TDF or dolutegravir TAF. This looks at the types of drug mutations found, and in the unbolded, you see mutations that were detected at entry. So this is pre-ART, and the bolded mutations are new mutations found at viral failure. And the first thing you can see is there was a high prevalence of pre-ART drug resistance that really didn't differ between treatment arms, 77% with efavirenz, 83% with dolutegravir. But when you looked at new HIV drug resistance mutations, which were found in 47% of women, this was more frequent in the efavirenz arm. 1 of 20, 5% of dolutegravir failures had integrase inhibitor resistance. Most of the efavirenz failures were NNRTI resistance, no surprise, also some NRTI. This study is an update of the French perinatal cohort in France, where they looked at all infected women delivering between 2000 and 2017 at 90 centers in France. And just to remind you, there's no breastfeeding, free access to ART, and they did monthly viral load assessments. So this is looking at overall mother-to-child transmission by timing of antiretroviral start, before conception, first trimester, second trimester, third, and those on no ART. And you can see, obviously, maternal child transmission was lowest with preconception treatment, 0.1%. And the percent of women on preconception treatment increased from 28% to 66% in the more recent time period. This now looks at HIV transmission by time period and time of maternal ART start, with 2000 to 2005 in purple, 2006 to 2010 in orange, 2011 to 2017 in green. And you can see that the transmission rate decreased steadily over time, overall from 1.1% in the 2000 to 2005 period down to only 0.2% in the 2011 to 2017 period. And you can see the greatest decrease was actually seen in women taking drug prior to conception. This looks at gestational age at delivery and overall, and then by the most recent period. So preterm delivery has been associated with a higher maternal child transmission rate in women without HIV infection. And overall, they continue to find that preterm delivery and very preterm delivery were more frequent. But if you looked at the more recent period in red, when most women were suppressed from the first trimester, there was not an association of transmission with gestational age. So initially there was, but now when we're looking at women who are mostly starting preconception, there was not an association of preterm delivery with transmission. And then finally, they looked at maternal to child transmission in women on ART at conception according to viral load at delivery. So among over 6,000 women on ART at conception, the proportion that were virally suppressed at delivery increased from 70 to 93% in the most recent time period. And there was no mother-to-child transmission in 5,482 infants born to mothers who were on ART at conception and had undetectable viral load at delivery. So U may equal U in non-breastfeeding women. Now looking at infant outcomes and ARV drugs. This is going back to the vested trial. They had lots of presentations during CROI. These are looking at women who were enrolled in vested and had subsequent pregnancies after they delivered. So there were 20 subsequent pregnancies on study while they were receiving treatment at conception, either dolutegravir TAF, dolutegravir TDF, or efavirenz. So there were adverse outcomes in 58% of the pregnancies that conceived on treatment, 35% spontaneous abortion stillbirths. And you can see comparing dolutegravir is in green here, efavirenz is in purple. Adverse outcomes were more frequent with efavirenz at conception, 8 of 12 or 67%, than women on dolutegravir at conception. And of the 7 women who had fetal demise, there was a history of prior adverse outcome before in 5. So 5 of 7 had a history, and there were no birth defects. So this looks at birth outcome by a week from index pregnancy and what the women were receiving. So the lines show you the new pregnancy. In purple, you see efavirenz, greens are dolutegravir, and the little red circles show you either spontaneous abortion or stillbirth intrauterine fetal demise. So there were 7 stillbirths or spontaneous abortions. And if you look at those red circles, all of them except 1 were in women who were on efavirenz at conception, and there was 1 in women on dolutegravir at conception. This study looked at growth of infants from the vested trial, comparing dolutegravir TAF, dolutegravir TDF, and efavirenz. So they looked at infant growth through age 50 weeks. So here we see in the darkest green is dolutegravir TAF, the kind of light green is dolutegravir TDF, and in purple we see efavirenz. So here we see length for age z-scores, and we also see the percent that had stunting. And you can see just looking at the color purple that the lengths for age z-scores were lower and the rates of stunting higher in the efavirenz versus the dolutegravir arms. And they were similar between dolutegravir TDF and dolutegravir TAF in the green. Looking at weight for age z-score, you see the weight for age was lower in efavirenz compared to dolutegravir and similar in the TDF versus TAF dolutegravir. And they found no difference in weight for length by arm. The mechanism for the improved growth with dolutegravir is unknown, but it may be because there was better maternal weight gain with dolutegravir than efavirenz. This is looking at the PROMISE trial, where they did a sub-study where they followed infants and did DEXA scans looking at infant lumbar bone mineral content at entry in week 26 with central readings. And they also looked at renal function by looking at infant creatinine clearance. So this looks at infant entry and week 26 lumbar spine BMC by study arm. And the study arm was either maternal treatment with TDF-ART versus infant nevirapine prophylaxis without maternal treatment. And you can see that, the maternal TDF-ART is in dark green, and in blue, you see infant nevirapine prophylaxis. So at entry, there was no difference between bone mineral density. However, by week 26, the infants of mothers receiving tenofovir treatment had lower BMC than those who were receiving infant nevirapine prophylaxis. But the mean difference was only 0.13 grams. And so it's much less than a half a standard deviation. So the clinical relevance of this is not completely clear. And this looked at infant calculated creatinine clearance. And you can see, just looking at the graph, there was no significant difference in creatinine clearance or renal function by study arm in infants. This is data from the CDC, where they used Market Scan commercial claims database and the Medicaid database and looked at pregnancies in women of childbearing age and developed algorithms to be able to estimate the time of conception, identify pregnancy outcomes, and then look at neural tube diagnoses. An early pregnancy here was defined as 8 weeks before conception to 13 weeks gestational age. So here we have women in orange without HIV, women with HIV receiving dolutegravir early in pregnancy, a little purple and green, and women with HIV receiving other ARVs during early pregnancy. So the first thing you can see is that women with HIV had higher rates of stillbirth and pregnancy losses compared to women without HIV, despite the fact that they were on treatment. There were very few neural tube defects and no significant difference in neural tube defects comparing women with HIV with early dolutegravir compared to those receiving other ARVs or receiving women without HIV. So the number of early dolutegravir exposures and the number of NTDs here are still relatively small, but these are reassuring data. And this comes from the European Dolomite study, which is a multi-country cohort, and they looked at 550 pregnancies in where women received dolutegravir. And they defined periconception dolutegravir as initial exposure at 6 weeks or less estimated gestational age. So this looks at pregnancy outcomes in HIV-positive women on dolutegravir. In the induced abortions, one of the 18 induced abortions was due to a CNS defect, but not a neural tube defect, a neural migration disorder, and that woman had received dolutegravir periconception. Of the 27 stillbirths and spontaneous abortions, all of those occurred in women on dolutegravir at periconception, and none of them had defects. The overall birth defect rate was 3.9%. There were no neural tube defects, and the rate of defects really didn't differ between periconception or second or third trimester, and the types are shown in the box. They also looked at rates of preterm delivery in yellow, very preterm delivery in orange, low birth weight in light green, and very low birth weight in dark green by timing of exposure. And you can see the rates for all of these adverse outcomes were either lower than or similar to exposure in later trimesters. So no association of preterm or low birth weight with periconception dolutegravir. The final section is talking about PrEP in pregnancy. And the first one is looking at longitudinal PrEP use in 330 HIV uninfected women who were planning pregnancy as part of a safer conception package in South Africa. Most of these women didn't know the status of their partner. 60% of the women initiated PrEP. Median adherence during follow-up was 63%, which is actually higher than most studies. Adherence was highest in the first 3 months, 73%, and then decreased over time, but was still 62% at 12 months in these women who wanted to become pregnant. When they looked at adequate adherence, defined as either 80%, greater than 80% MEMS cap opening, or tenofovir levels that were greater than 40 nanograms per ml, the dark blue is MEMS, the light blue is tenofovir. Only 36 to 40% had adequate adherence at 3 months, and this decreased to a low of 14 to 25% at 12 months, so a little bit less reassuring. HIV incidence overall was pretty high, 4.04 per 100 person years, but it was lower in those who started PrEP, 3.66, to those who had not initiated PrEP, 4.62. And the 5 PrEP users with HIV infection all had adherence less than 80% by MEMS cap, and the others had at least a PrEP break and a new partner. This is now the PRIMA study, again in South Africa, looking at women starting PrEP in pregnancy, and they had randomized them to different implementation strategies. Most of these women were married, 20% knew their partner's status, and they looked at PrEP persistence and self-reported adherence during pregnancy and postpartum. 58% persisted in PrEP use at 9 months postpartum, that's pretty high, with 53% reporting not missing pills in the last 30 days. And then they looked at the correlates of PrEP persistence at 9 months postpartum and found that women with age 24 years or older were 1.6 times more likely to persist with PrEP use. Women with a partner who knew that they were HIV positive or with a positive syphilis test were more likely to persist. And in younger women, less than 24 years, higher educational attainment and more lifetime partners were more likely to persist with PrEP use. This is another PrEP study, again from South Africa. This is offering PrEP during pregnancy, following up postpartum, and they looked at pregnancy and birth outcomes between women who used PrEP and women who did not use PrEP during pregnancy. So here you can see that the blue represents the total population, orange represents PrEP exposed, and gray represents PrEP unexposed. And so if you look at pregnancy losses, miscarriage, stillbirth, or termination, you can see that the PrEP exposed group had less miscarriage or stillbirth compared to the PrEP unexposed group in gray. And then there was no differences in birth outcomes between PrEP exposed and PrEP unexposed pregnant women when you look here at term delivery, preterm delivery, neonatal death, low birth weight, SGA, et cetera. So among PrEP exposed women, there was no association with duration of antenatal exposure and birth outcomes, and no difference in outcomes by PrEP exposure in pregnancy. So very reassuring. The REACH study was a study in adolescent girls looking at the dapivirine ring versus oral PrEP. And in this study, they were randomized to either the dapivirine ring or oral PrEP for 6 months, followed by a crossover to the opposite treatment for 6 months, And then they were offered a choice of either. So this is looking at adherence to product. And just to give you what these colors mean, for ring adherence, they used the estimated Depivarine ring residual drug. So orange would show you no use, yellow would show you some use, green shows consistent use. And for PrEP, they looked at tenofovir diphosphate levels in dried blood spots. Again, orange is non-use, yellow is some use, and green is high adherence. And you can see the top line is oral PrEP and the bottom is the ring. So overall, girls used both the ring and oral PrEP consistently during the crossover and choice periods with either some or high adherence, and fewer than 5% of visits were characterized as no or low adherence to study products. This is pretty good. And then if you looked at product choice during period 3, 97% of women who reached the choice period, more than 2/3 of those women chose the Depivarine ring over receiving oral PrEP. I think this is the last, and this looked at CAB LA safety. So in HPTN 084, if there was a positive pregnancy test, blinded product was withheld. The women received open tenofovir. If this was confirmed, then they stayed on tenofovir FTC throughout pregnancy and the cessation of breastfeeding. So this is really looking at exposure at conception. There were 49 confirmed pregnancies, 29 in the CAB LA and 20 in the TDF-FTC arm. So if we look at pregnancy-related AEs, there were more pregnancy-related AEs in the CAB LA arm than the tenofovir FTC arm, but all were judged unrelated to study product. This looks at pregnancy outcome by study group, live births, pregnancy loss, et cetera. And there were no differences in pregnancy outcome between women at conception exposed to CAB versus TDF-FTC, and no birth defects. And then they compared CAB PK in pregnant women in HPTN 084 in the orange to non-pregnant women in HPTN 077 in blue. And you can see from the curves that there was no significant difference, with the half-life 62 days in pregnant and 64 days in non-pregnant women. So residual CAB was well tolerated in pregnancy and wasn't associated with birth outcome, and PK was similar in pregnant and non-pregnant women. And I think that brings us to the end. Thank you.
Thank you so much, Lynn, for that fantastic overview of the abstracts at CROI. There were 2 questions that came into the chat, and they were both actually related to the French cohort study abstract that was in your pregnancy, HIV, and ARV drugs section. And the question was, whether or not the author specified the type of transmission. So whether in utero or perinatal, and by time of ARV initiation.
No, they didn't. It was just overall transmission.
Okay, great. And then the other question was, if they specified anything about the pregnancy postpartum period.
No, they didn't. And remember, these are non-breastfeeding women. So
yeah.
And a CAB given every 4 weeks versus 8 weeks. I think it was every, what was HPTN 084? I think it was every 4 weeks. I actually can't remember. Sharon, do you know? Are you still on?
I am on, and the question is, was it every 4 weeks they were, I'm sorry, it was every 4 weeks?
The injections, was it every month or every 2 months?
No, it was bi-monthly after the first month.
Okay, thanks.
All right, thank you, Lynn. We're going to have to move on to our next speaker, who is Caitlin Moran. She's an infectious disease specialist and assistant professor at Emory, and she is going to be giving us an overview on the abstracts on HIV, related to HIV and comorbidities in women. So take it away, Caitlin. I know you've got like 15 minutes to do this. So,
all right, thanks, Phyllis. I will try to talk as fast as I can and still be coherent. So here is a quick outline of my talk. I'd like to start just with a quick disclaimer with the task of focusing on comorbidities in women. There were relatively few abstracts that focused solely on women, and not all abstracts reported either the sex of participants or reported on sex differences. So what I've chosen to focus on here is those abstracts that looked at comorbidities that are relevant to women's health, and in particular in women living with HIV. So I'm going to start by presenting a few abstracts related to overall survival. And this is CDC data looking at life expectancy after HIV diagnosis between 2008 and 2018, using national HIV surveillance data on all persons who were 13 or older at the time of HIV diagnosis. And life expectancy estimates were generated for various demographics. The good news is that in this 11-year period, the life expectancy for people with HIV increased by an average of 1.3% per year. However, there were significant sex differences. The life expectancy for males was longer than for females over in 2018 and over this time. And males had larger gains than females did over this time as well. And this was true when broken down by various sex and race categories, as you can see here. This next study is a reprieve sub-study that looked at geographical differences in functional impairment of people with HIV. So the reprieve cohort is a global cohort of people with HIV ages 45 to 75 on ART. The parent study is looking at pitavastatin and cardiac outcomes. But this particular sub-study looked at different global burden of disease regions, and participants self-reported their functional capacity using the DAISY score. These are the GBD regions that were represented in this study. There were over 7,700 participants, 35% of whom were female, and 36% of participants reported at least some impairment. The least impairment was reported in the Southeast and East Asia regions, and the greatest impairment reported in the South Asia regions. Female sex, along with older age, Black race, current and former smoking, higher BMI, and ART duration greater than 10 years were all associated with greater impairment, as you can see by the forest plot here. This study looked at mortality associated with cancer in people living with HIV in South Africa. So these were adults in a private HIV management program between 2012 and 2018. And mortality data were obtained from the South African National Population Register. The outcome of this study was excess life years lost, and these were estimated for both HIV-related and HIV-unrelated cancer types. So they had over 120,000 people in their cohort, and they had 2,675 cancer diagnoses. Overall, women lost more years of life to cancer than men did in this study. And you can see here the different types of cancers that were represented and the ages, median age at cancer diagnosis. And looking at this graph here, you can see that for pretty much every type of cancer, women had more excess life years lost than men did, even in cancers that are typically associated to be or thought to be more male predominant, such as lung cancer. I'm going to switch gears a little bit and talk about HPV-associated disease. I'm going to set the stage first by talking about the ANCHOR study, which results were presented at this year's CROI. As you all know, the ANCHOR study enrolled people with HIV 35 and older with anal HSIL, randomized to active monitoring versus treatment, and their primary endpoint was time to incident anal cancer. Over 10,000 people with HIV were screened for this study, and over half had HSIL to be enrolled. And importantly, almost half of all women who were screened for this study also had anal HSIL, which was surprising to the investigators. 16% of the cohort overall was female. And the trial was stopped early for efficacy, as there was seen to be a 57% reduction in anal cancer in the treatment arm. And you can see the survival curve here. In contrast to the ANCHOR study, this study looked at the prevalence and severity of HPV-associated anal disease in people with HIV who are younger than 35. This was a single center study in the US, and they looked at anal pap smears and anoscopy biopsy results from 2014 to 2020. This is a predominantly male cohort, over 93% were male. It's a much younger cohort. And the vast majority had some degree of cytologic abnormalities as well as high-risk HPV. And you can see that the cytologic abnormalities persisted throughout age groups with greater abnormalities in the older age groups compared to younger. What was interesting in this study, in contrast to Anchor, was that women actually had less HSIL than men, 8% versus 22%, although the numbers of women in this study were small. This study also in the US looked at women with HIV and HPV co-testing results from both anal and cervical pap smears. And this was again between 2012 and 2019. And what they found is that in the slightly older cohort of women with a median age of 49 years, they found that ascus or greater was more prevalent in the anus than the cervix, and that high-risk HPV subtypes, and particularly HPV 16 and 18, were detected more frequently in the anus than the cervix, suggesting that we should be screening at both sites. And this final study in this section looked at HPV genotyping in women who were being treated for HSIL. So this was a secondary analysis of a randomized controlled trial, the MHAVE study. And the overall structure of this trial was using adjuvant quadrivalent HPV vaccine for women with HSIL who underwent LEAP. And you can see the study design here. This secondary analysis looked at leftover tissue from LEAP as well as recurrent cervical HSIL specimens from colposcopy biopsies. And the outcome was looking at HSIL recurrence as well as differences in HPV genotypes. And so not surprisingly, there was a very high prevalence of high-risk HPV at all time points. And HSIL present at the LEAP margins was predictive of recurrent HSIL. Interestingly, there were no differences in HPV genotypes in recurrent specimens that were attributable to the study assignment. So vaccination with the quadrivalent vaccine did not actually change the genotype of high-risk HPV that was present. Moving on to cardiovascular disease, again, to kind of set the stage here, this was a study in two cohorts in the US, in the Kaiser Permanente, Northern California, as well as the Massachusetts General Brigham cohort. And this looked at trends in MI risk by HIV status. So participants were identified between 2005 and 2017, followed through 2020, and looked at in two different time periods, from 2005 to 2009, and then from 2010 to 2017. I was a predominantly male cohort with a mean age of 43 years. And what you can see here is that at the earlier time periods from 2005 to 2009, there was actually no difference in incident MI by HIV status. However, in the later time periods, the HIV negative patients saw improvements in incident MI while there was really no change in incident MI among persons with HIV. And so those curves started to separate. And in a sensitivity analysis, that involved only women in the study, similar inferences with reduced precision were made. So this study looked at subclinical atherosclerosis and immune activation among US females versus males with HIV, and this is another REPRIEVE sub-study. And so this is a subset of US REPRIEVE participants who underwent coronary CT angiography and immune phenotyping at study enrollment. It included 631 males, 141 females with a median age of 51 years. Unsurprisingly, plaque prevalence was lower for females than for males, but among those with any plaque, vulnerable plaque features did not differ by sex. And so you can see the breakdown of vulnerable plaques by males and females here. And then looking at the immune analysis, females showed higher levels of inflammatory biomarkers, including IL-6, high sensitivity CRP, and D-dimer. Overall had a lower percentage of total monocytes, but they did have a shift towards a higher percentage of inflammatory and patrolling monocytes compared with classical monocytes. This was a really interesting study from the Max Wise combined cohort study that looked at gut microbiota, plasma metabolomics, and atherosclerosis. And it involved a cross-sectional study that included women who were enrolled in WISE, as well as a longitudinal study that included both women in WISE and men in MAX. The cross-sectional study looked at gut microbiota features and prevalent carotid artery plaque in women between 2017 and 2019. And the longitudinal study looked at lipidomic and metabolomic profiles with incident carotid artery plaque over a median 7-year follow-up period. And what they found were that among the women in the cross-sectional study, as well as the women and men in the longitudinal study, Proteus and Fusobacterium were associated with prevalent and incident carotid artery plaque. And that in their lipidomics analysis, lysophosphatidylcholines as well as diglycerides were longitudinally associated with carotid artery plaque incidence, and that these were tied back to those pathogenic bacteria that were seen. Moving on to metabolic disorders. This is another study out of WISE that looked at sleep disruption and kynurenine pathway activation in women with a risk for HIV at Chicago, Bronx, and Brooklyn WISE sites. These women wore a wrist actigraph device for 10 days, and plasma tryptophan kynurenine pathway metabolites were measured. So 153 women with HIV and 151 HIV negative women with a mean age of 52 years were included. You can see here there were no differences in tryptophan levels by HIV status, but there are higher levels of kynurenine and therefore the kynurenine to tryptophan ratios in HIV viremic women compared to HIV positive women who were aviremic, with the lowest levels in HIV negative women. And interestingly, higher KT ratio was associated with more wake bouts, greater sleep fragmentation, and lower sleep efficiency in women with HIV only, compared with HIV negative women where those associations weren't seen. However, when looking at inflammatory biomarkers, they were pretty much associated with the kynurenine and the kynurenine to tryptophan ratio in both HIV positive and HIV negative women. This study looked at terminology looking at liver disease. And there's been a movement in the GI field moving into the ID world to redefine NAFLD or non-alcoholic fatty liver disease to metabolic associated fatty liver disease based on positive diagnostic criteria. And so this authors here looked at prospective cohorts of people with HIV on stable ART who were screened for fatty liver disease. NAFLD, of course, is defined as fatty liver disease without alcohol or viral hepatitis. MAFLD is defined as hepatic steatosis in the presence of overweight or obesity or type 2 diabetes, or in those participants with mean or normal weight, the presence of at least 2 metabolic risk abnormalities. This study included 1,947 people with HIV with a mean age of 54 years and 74% male. And there was considerable overlap, although not complete overlap, in the definitions between NAFLD and these various NAFLD criteria. And this actually becomes important when looking at risk stratification, because there are some gender associations in some risk categories compared with others. For example, people with HIV with MAFLD and diabetes or overweight obesity had a higher risk of liver fibrosis. However, people with MAFLD and a lean or normal body weight did not, and there are different gender associations there. And this study looked at inflammation and kynurenine pathway and linked it to type 2 diabetes and fat fibrosis in HIV. And this, the authors utilized the CNIX cohort here, and these participants did not have prevalent diabetes and were frequency matched by hemoglobin A1C to HIV negative individuals in the SCOPE cohort. They looked at plasma biomarkers and incident type 2 diabetes and insulin resistance. There were 97 incident type 2 diabetes cases among 843 CNIX participants. 16% of the cohort was female, and type 2 diabetes was linked to BMI and antihypertensive use, and there was a trend towards female sex. And there were many inflammatory pathways that were invoked that predicted type 2 diabetes incidence in people with HIV. However, when stratified by sex, soluble TNF-R1 was associated with type 2 diabetes incidence in men, but not in women, suggesting there may be some different pathways there. And for the very last section, just 2 more abstracts looking at weight gain and ART. This is another study out of WISE that looked at the predicted impact of ART switch on body mass index. And it included virally suppressed women with HIV between 2014 and 2019. And the authors used Bayesian machine learning models to estimate the combined effects of ART regimens on BMI. And they compared predicted BMI with the actual BMI and determined those ART regimens that would lead to a BMI reduction of greater than 5%. So there are 1,532 women included with a mean age of 48 years. Black race, being from the Birmingham, Alabama or Jackson, Mississippi sites, diabetes and a higher CD4 count were all associated with higher BMI. In about 3/4 of women, ART switch was not predicted to lead to a BMI reduction. However, in those who did have a predicted BMI reduction, an efavirenz or a boosted anizanavir-based regimen accounted for most of the predicted BMI reduction. And you can see the graph over here. The plots in green are those that are statistically significant, the red are not. And this blue dash line indicates either weight loss on this side or weight gain on the other. And then finally, this is a study looking at weight change following switch to dolutegravir in rural Kenya. Looking at 8 different HIV clinics and participants who were 25 years or older. All had been stable on ART for at least a year prior to switching to dolutegravir. And they looked at the predicted post-switch weight trajectory kind of as a counterfactual approach if the participant had not switched to dolutegravir and contrasted that with the observed. These are the baseline characteristics. The cohort was about half women. The vast majority were of normal weight, and almost everyone was on efavirenz prior to switching over to dolutegravir. And what you can see here in the predicted in the breakdown by sex as well as by weight category, there were really no significant differences in the observed versus predicted, and they did not see significant weight gain after switching from efavirenz to dolutegravir in this setting. So that is all I have, and I am happy to take any questions if there's time.
Caitlin, thank you so much. That was an amazing job getting through those abstracts. We are at the top of the hour. So, if the people have questions, please send them to us or Caitlin directly, or if you still have questions for Lynn, please send them to Lynn. And I just want to say thank you so much for joining us today for our first webinar of the year. And our plan is to continue to hold these webinars. The next one will be in June, followed by one in September. And we are going to continue this type of seminar speaker format, but I hope that our next webinar will also be able to discuss the mission of our working group and some of the goals that we are working toward for the next year or two. So thank you so much, everyone.